Hello, everyone. My name is Greg Fritz. I'm a doctor of physical therapy and a specialist in musculoskeletal ultrasound imaging. This is an effort to see whether or not there is traction within the space of information on musculoskeletal imaging. I'm hoping this has some clinical applicability, because I've found it in my own practice, and I'm wanting to have you try it on through listening and seeing if it has any applicability in yours. Today's lesson is going to be on fatty infiltration in general, but I'll be using mostly the shoulder, taking a look at rotator cuff muscles and tendons to see, or at least to demonstrate, the utility of musculoskeletal imaging in that area. But those of us in physical therapy certainly know that if we took a look at the multifidus or any of the other paraspinal musculature, there is a propensity to lay down intramuscular adipose tissue in that region. And I look to develop some lessons in the future that will critically take a look at research and even imaging to see whether it's possible for us to categorize patients with low back pain. Is it possible for us to also monitor and progress a patient forward with imaging that region? I regret I don't have any images in this presentation. I'm trying to keep these presentations short, and this particular one is about general muscle change and what we can see with ultrasound imaging in muscle tissue. Let me just ask with a head nod if you're seeing a shoulder in front of you out there. All right, and let's see if we can just start in. The shoulder, as you take a look at here, can you see my pointer on it too, out on the actual, do you see me moving this around? Thank you, guys. This is the scapula. This is the spine of the scapula. This is the medial scapular border. And you know that at the end of the spine of the scapula is the acromion. And in the view, through a faded supraspinatus muscle, is the clavicle. So we're going to go ahead and start the presentation. At least that is my attempt to start it. There we go. And hopefully it doesn't catch up with every click I just made. There we go. And this is a ribeye steak. It is a fairly normal grade ribeye steak, and you can see around the ribeye an endomysium, and we have little areas within the steak slice that's called a fibroadipose deposit. We have also areas within the steak slice that is a intermuscular aponeurosa that come together as we get closer to the insertion to form a tendon. But visually, as you take a look at ultrasound images and you see muscle structures, this is exactly how it's going to look. And so I'm going to show you this as the normal muscle. And we're going to now move to what I'm calling a lean muscle. This is an elk ribeye. This elk ribeye is showing very little intramuscular adipose tissue, very obvious collagen where the epimysium or the paramysium circle the actual muscle structures and differentiate it from the other components of the ribeye. But this is, brace yourself, what is called Wagyu steak of the ribeye. And you can see the fatty infiltration in this one that brings out flavor to people who are connoisseurs. And I actually stole this picture off the internet. And this particular steak slice was $100 if you wanted to buy it online. And an entire ribeye sequence was up to $700, depending upon how much this infiltration of fat is that you can see. But what I want to point out to you is that there's very little fascicular structures here at all, as we see this fatty infiltration coming into this wonderfully juicy meat, I'll bet. Here is, however, the first step in the direction of how this applies to us. Additionally, over here on the left, you're going to see another piece of steak, or at least what looks like a rib I don't know my stakes, but anyway, you can see the fatty infiltration in here. You can see the cloudy structures within here. And this is a CT scan of the thigh muscle off to the right. You'll see that in the one directly adjacent to these pictures, there is fatty infiltration within the muscle structures themselves, where the intramuscular adipose tissue has a total of 18.8 centimeters squared surface area in that slice. And at the same level on a different patient population, you can see that this is a fat layer. This is the subcutaneous adipose. And if we compare patients that have intramuscular adipose tissue and fatty infiltration in their muscles, compared to those that are just plain fat, the heavy ones have layers of adipose and they're functional. Now, granted, they're tired when they go upstairs and they may have a hard time standing up from a chair, but functionally, they are far more capable clinically to present themselves healthfully at our clinic than those that have fatty infiltrations, making this clinically applicable. Really quick, because I thought this was a little bit interesting, one of my fellow sonologists is literally looking into doing beef scans in Texas. There is a 6-digit figure if you can get this contract to do beef scans in Texas. However, taking a look up here, you can see a ribeye steak on top of what's going to now fade away, and you're going to see how poor their quality of ultrasound imaging is. You can see some adipose, you can see some fat layers in it, but this is a slice right here, number 2, between rib 12 and 13, which brings up another shiny thing I had to look up. I was ignorant enough to think that all mammals had 12 ribs. I didn't even know that if you take a look, when I looked it up, because it was distracting, whales have 9 and sloths have 24 ribs. Didn't even know that. Anyway, this is another application of looking at fatty infiltration in muscle. And just to give you a comparison, here's a cow probe, and coming on top of that is the probe I use in taking a look at these muscles right here. So here we have the small human probe and the bovine one. Getting to some specifics as to why fatty infiltration is relevant, it's a good prognostic indicator in rotator cuff tears. In fact, they attempted to compare just general atrophy, fatty infiltration, and fibrosis to see which one had the most direct applicability to functional outcomes. And they took a look at and found that it was fatty infiltration that had the most directly correlated findings. And here is the Mercedes sign of a scapula on a rabbit. And you can see this is infraspinatus, this is supraspinatus, and this is subscapularis. Also, how long does it take for fat to start to develop? If a person is completely still, within 3 days, we start to see fibroadipose layering within previously contractile muscle. And this particular one is what's evidence of why I find using it in the practice of physical therapy is so relevant. It has a direct correlation to what MRI shows as far as identifying fatty infiltration comparatively. So I want to show you the anatomy of focus that I want to focus on today. Let me see if I can actually turn this skeleton around. We're going to zoom in on the left scapula. I'm going to actually populate that scapula with some muscles here. And as I do that, you should be able to see that in this particular picture, that's the supraspinatus, that's the infraspinatus, and that's the triceps. That's the teres minor. And I want to have you realize that these are the muscles we're going to be attempting to identify quite specifically today. I'm going to lower this down. I'm going to zoom in, and I'm going to actually cut a cross-sectional area out of this shoulder. So we're going to slice through here. We're going to slice through there. And then if you watch closely with me, I'm going to turn, and then we're going to rotate that whole item like so. So as we take a look at the scapula, I want to point out this again is the supraspinatus, this is the infraspinatus, and this is the teres minor. These are going to be important structures for you to be able to identify on the next series of slides. So speaking of that, let's to the next slide. There we go. So what I want to have you now realize is that we already pointed out that we're looking at the teres minor here, the infraspinatus here, and the supraspinatus up here. But in this drawing, I've actually called out the deltoid over the infraspinatus and the upper trapezius over the supraspinatus. And we're going to be scanning in what's called a slice scan or a skate scan. We're going to be cutting right through the structures of the rotator cuff like such. And then we're also going to be doing what's called a sweep scan. And in a sweep scan, we're going to be taking a look at the muscles from origin to insertion. Let's start doing that. Here on the left, on this particular slide, I want you to notice that where I'm indicating with my finger pointer here is the end of the scapula. And this is the infraspinatus fossa. If you take a look at the diagram to the left, the region of interest is covered in the white. So what we're looking at is infraspinatus. We're looking at the fibroadipose septae up here, and this again is bony. So I'm going to hit start. Hopefully that will start it, and it doesn't from here. Let's go to there. Good. Now you're seeing infraspinatus. You're seeing teres minor here. And by the way, let me just stop this for a second. And I want to point out that in this particular image here, you're also seeing serratus anterior. Serratus anterior is coming in to attach to the scapula right here. But this is teres minor. And as we continue here, we're going to come back through infraspinatus. Then I'm going to go up and over the spine of the scapula, and we're going to drop into the supraspinatus fossa, above which is the upper trapezius muscles. So again, I've sliced this. This is a slice scan of the rotator cuff muscles. We're going to go on now to the right side of the screen, where you're going to see now that I've also slid the probe inferior to the teres minor as well. But what I want you to watch is that I'm going to now sweep scan it toward the humerus. So here we go. We're sliding toward the humerus, and you can see what started out to be the fibroadipose structure. Let me go back to the the teres minor. So what we started out to have as the intramuscular aponeurosa begins to come down all the way to a tendon where it inserts onto the inferior facet. This is the infraspinatus. It comes down as well, and you can see that I've gone back and forth on the infraspinatus, and this aponeurosa right here is coming down, and it will become a tendon entirely, and that tendon will insert onto the middle facet of the head of the humerus. And so that you know the orientation above the infraspinatus, this muscle here is the deltoid muscle. Now, let me see if I can move on now to the next slide here. What I'm going to show you on this one is a very muscular patient. And this muscular patient, if you look at this region of interest that I'm pointing out on the bottom left, this is teres minor. So we know this to be the deltoid above it. So I'm going to go ahead and hit play on this. Teres minor, this is the scapula here. I'm going to then go across. You're going to see the infraspinatus right here. And watch as I follow that infraspinatus all the way up to where it becomes a tendon. So we're getting close to the head of the humerus. And that infraspinatus is just about ready to become entirely tendon as we get to the head of the humerus and going on to the middle facet. We're going to keep going here. I think I might go up and over, and it becomes the supraspinatus. Yes. And look at that. Look at the quality of this meat. It's like elk meat, how we don't have much fatty infiltration there. And again, above it, we have the upper trapezius musculature right there. I'm going to take you back to an important component of this, and that's where we came all the way on the infraspinatus, and we were able to see, let me see if I can, there we go. We were able to see the tendon material of the infraspinatus. Over to the right now, if you can take a look at the bottom right-hand screen, you'll see this gray line right here is identifying what the structures are on the picture below. This structure here is the glenoid, which is part right here of the scapula. The structure I'm pointing to right now is the labrum, which is that fibrotic disc between the glenoid and the head of the humerus. And here we see the articular cartilage of the head of the humerus. That means what we're looking at right here is the long image of the infraspinatus muscle. It is the infraspinatus tendon, above which is the deltoid. So I'm going to hit play on this, and you'll see that the patient is internally and externally rotating their arm. And what you're seeing here is this intramuscular aponeurosa coming in and out of view into its primary tendon insertion on the middle facet of the humerus. We'll move on here to the next one. What you remembered before, which is that long tendon of the infraspinatus, I want you to be aware of. This is a patient that tendon is torn on. So we again have the head of the humerus. We have where the tendon should be in its entirety, and I'm going to go ahead and hit play on this one. You're going to see I'm asking her to internally and externally rotate that muscle, but this big wad, this big area under the screen right here, like a snake in a bag, is a wound up infraspinatus tendon. And as she internally and externally rotates, it does not functionally move her infraspinatus. And in fact, if you look at it, it's bright. It is fibrotic. That muscle that we're seeing right there is the infraspinatus that is atrophied and fibrotic. Now, I want to show you that I've turned now, and I'm looking at the short axis area, and you're able to see that I'm differentiating. Let me pull this back where you can see. There we go. Hopefully in your view right there, you can see that her teres minor, which is right in the center of the screen right here, is actually well preserved. Infraspinatus is fatty. Teres minor is well preserved. Now that's our backup muscle. You know, it's rotated, it's an external rotator, so it's a backup muscle for the infraspinatus. And in her case, because of all this fatty infiltration and the fibrotic material, she was simply not a candidate to reattach the infraspinatus, and the teres minor served as an able backup for that. Here we have, in her case, infraspinatus atrophy and teres minor hypertrophy. In this next case, hopefully I can get us over there. Here we go. To the right, you'll see infraspinatus preserved and teres minor having fatty atrophy. So teres minor, let me see if I can pull this back right here for us to see. There we go. Teres minor is fatty infiltrated, which is very odd because teres minor is axillary nerve innervated, and infraspinatus is suprascapular nerve innervated. The unique thing as well is that above this is the deltoid muscle, and the deltoid muscle itself is also axillary. So as a diagnostician myself, looking at this going, why is it that the teres minor is atrophied and fatty infiltrated, but the deltoid is not? The answer is that the deltoid is from the superior fibers of the axillary nerve. The teres minor is inferior fibers, or if you look it up and I'm wrong, it's the opposite of that. However, going through the quadrilateral space, pressure put nerve pinching on the teres minor, and we were able to differentiate why it is his infraspinatus is preserved, his deltoid is preserved, but the teres minor shows fatty atrophy. Now, I'm going to also take a look next at the back of the shoulder blade, where you can see already the image of the infraspinatus that you've already learned to identify here. This is the infraspinous fossa, the infraspinatus fossa. And of course, again, this is your teres minor. But I want you to watch on this particular scan here. Teres minor looks well preserved. It has good heterogeneous appearance. And we take a look here and we can see there's a fibrotic area in the infraspinatus, but look with me at the bottom of this. There should be no darkness between infraspinatus and the bone of the scapula. This darkness was an interesting it offended me in the picture because there should not be anything dark, especially this dark, between muscle tissue and the scapula. So I turned the probe 90 degrees. We call it orthogonal. This is long axis infraspinatus in the bottom right. And this is a very large paralabral cyst. And if you look close, that's fluid that's coming from the labrum. Here we'll come past the glenoid. Glenoid is right over here. The material under the infraspinatus is all a fluid-based cyst, and that cyst is pressing up on the spinal glenoid notch, which is compressing the suprascapular nerve, and it's bringing about fibrotic infiltration of fat into the infraspinatus. This patient was just last week, and it was a physical therapist who identified this particular patient in simply having weakness in external rotation. And that's how it became on my schedule, and we were able to help identify the paralabral cyst in that case. So, talking to you, my referral sources or individuals who would be able to use EchoHealth imaging, studies like I've just done shows just one component of what we take a look at when we're doing a full shoulder scan. And after a full shoulder scan is complete, you will have access to PACS, or an imaging assessment device, online. You will get through your email an invitation to identify that particular patient study. And in that study, you'll see a printout that will have, or a digital PDF file that will have images like this, in which you will see that supraspinatus or suprascapular and supraspinatus fossa that holds the supraspinatus muscle, over which is your upper trapezius. And you will also find that there's the infraspinatus image, which has that teres minor view and the infraspinatus, as well as the deltoid over the top of it. And for your own information, in this particular study, it's important to point out that all of the shoulder muscles showed a certain part of fatty infiltration. So all of the muscles were deconditioned. Now, if the upper trap was healthy, if the deltoid was healthy, if we saw that the teres minor was healthy, but that there was a single muscle that was deconditioned, that would be able to say we have a focal area to work on exercise-wise. Let's see if I can go on to this last one. Like I told you to begin with, the scapula itself is what we focused on today in most of our primary imaging scans for your review. I have several examples of how this exact same theory of identifying fatty infiltration in contractile tissue continues to be of value to us. This is another example in the arm. And if you take a look at the top right, you'll see that this is an anterior view of the left shoulder. You'll see that there's this long tendon, which is the long head of the biceps, and medial to that is a shorter tendon, which is the short head of the biceps. And if you take a look at this black line, that's where I've placed my probe for this picture right here. And to call it out even better, here is an inferior view looking up at the exact same picture. Here is the short head of the biceps, and that's this area right here. Here is the humerus cut across, and that's this structure right here. And lastly, because I've already told you, but because we know that the long head of the biceps has been torn, it has retracted and given us that same snake in a pillow slip. How about that? A snake in a fabric bag. It's rolled up and wound up. That's this region right here. But since today we're talking about fatty infiltration, I'm going to play this, and you'll be able to see as it plays. This is the short head of the biceps, and you'll see a big cloudy representation of the long head of the biceps right here. So that when it stops, you can see that what this is somewhere down here on the right picture, or over here on the one on the left. And this is all fatty infiltration. It's cloudy, and it gives us reason to say this muscle is pretty much shot. We're not even going to be able to get this to come back if we did a tenodesis and did a reapplying of the tendon within the bicipital groove. Now, let me see if I can go on to these structures here. What do we see? When do we see fatty infiltration? When there is a reduction in fiber loading. To those of us that are physical therapists, that makes sense. When fibers do not get overloaded to develop hypertrophy, the opposite of that is that fibers will start to receive fatty infiltration. When there's a reduction in contractile cycles, meaning that somebody is used to moving that muscle frequently, and we've aggressively reduced those cycles, fatty infiltration will start to go into that. When there's a reduction in or a loss of neural stimulus. Well, that was shown in that teres minor video we saw, where muscles themselves started to become fatty infiltrated simply because they do not have electricity to them, allowing them to go into a load and an unload. And fatty infiltration occurs in diabetes, with aging, and in the taking of various types of hormone therapies. And finally, to you, does this seem to have clinical value? Or at least to me, where did I find this to have the greatest clinical value? Well, we can tell how diffuse or how generally spread is this person's deconditioning. Is it throughout the whole shoulder or just isolated to one of the muscles in the rotator cuff? Another question is it a focal lesion? Meaning, is it something that we can find within the muscle, or is it something limiting the muscle? And I turn your mind to femoral acetabular impingement, or where there's a cam buildup on the femur, not allowing that muscle to move. To remove that obstruction would allow that muscle to actually function. We can also decide how advanced is the fatty infiltration. Is this person a surgical candidate? Where MRIs and CT scans are being used by insurance companies to totally limit whether a person can obtain surgery for rotator cuff repairs. I think it's just a matter of months, if not, a matter of months before insurance companies will start to say, have an ultrasound scan to evaluate whether you're even qualified to have the rotator cuff repair. And we can always also do side-to-side comparisons. And maybe even more relevant to our intervention, if we did another follow-up scan to a muscle that has shown fatty infiltration, are we able to identify that there's a darkening, or are there larger fibers of contractile tissue that represent that cross-sectional area? So I want to first thank you all for attending this, my very first video presentation. I want to remind you that they will not all be maybe theoretical like this one. There will be specific case studies that I would like to cover and at least provide for your review so that you can say, hey, is this relevant to the patients I have?